Today we have with us one of the renowned onco-anesthesiologists who is a roaring practitioner and HOD of Regional Cancer Center, Trivandrum, Dr. Mary Thomas. Welcome to MVR CanCon, madam. Good morning, madam. Today I want to ask you something about our onco-anesthesia practice. So you have been practicing onco-anesthesia for so many years now, and it's a renowned institute, Regional Cancer Center, Trivandrum. We have been grown hearing the name of RCC from childhood. That was the only cancer center which was there in Kerala, and whatever like onco means RCC. It was a practice like that. So you have been practicing there for this many years, and you have immense experience and immense knowledge. So I would like you to share some of the knowledge with us. So I want to ask you how the practice has changed over these years, and every time when the patient approaches to us, the concern of our anesthesiologist is also pain, and the patient's fear is also about the acute pain during surgery, immediate post-operative pain. So how over the years, how your practice has changed and how are you tackling that?
Yes, I think the public usually thinks that anesthetists are all the same. But I think in 2006, that was gave birth to the concept of onco-anesthesia as a subspecialty, especially when there was a thought that, the anesthetic drugs and agents that we give can decrease recurrence-free survival or decrease overall survival. So that's when all the anesthetists all over began thinking of as that we became a part of the oncology team in giving treatment. So in RCC, we have the multidisciplinary clinics, and they are all site-specific clinics. So when the patient directly comes, it is a referral center, and they came from outside. When they registered, immediately the patient goes to a clinic depending on the site of the surgery. So from then onwards, they're not treated by just one group of whether it's a clinical radiotherapist or medical oncologists or surgeons or anesthetists. It's a whole group for that site. And at that time, in the initial stage, they take a decision about what treatment should be given. And then they are sent to us. Sometimes they don't come up to us, to anesthetists, directly just for surgery. They might come as a team for prehabilitation, or they can come for pain relief, or they can be coming for working up for surgery. And so then we optimize them, see them whether they need cardiology backup or pulmonology, and if they have pain, we treat the pain. Previously, people used to think that if you take morphine, then okay, that is the end. It's the end. It's palliative stage. But now nothing like that is there. Some people are started on morphine. Some people are given nerve blocks. Pain is addressed initially because now WHO says that relief of pain is a birthright. It is your right to have pain relief, and that is what anesthetists are here for, to provide. So pain relief has increased dramatically. There are many methods with the advent of ultrasound. We not only give oral drugs, we give opioids, we give a lot of non-opioids which were not used for pain relief. Those drugs have been brought in. We give nerve blocks, we give epidurals. There are multiple things, and I think that my main concern for the patient, one is, of course, treatment of the oncology, the treatment for the disease that he has come for. Along with that is to maintain his comfort, to give adequate pain relief, and see to his safety of overall well-being. So now there are a lot of methods that patient can go home on taking pain relief. There's nothing to be worried of, any methods to monitor them. So I think we have now become a part of the integral treatment team rather than just giving anesthesia in the operation theatre and going. We start from the preoperative space into the OR. We are extending our care into the ICU, the HDUs, and even to palliative care. Now anesthetists are spread, I think. So we have a more comprehensive thing, and it's nice to see that a lot of patients are benefiting from all this thing and going.
Cancer means not every cancer is curable. So incurable cancers also, they have a lot of pain and agony. So to treat that, and we are getting a chance to treat that, it's a very nice thing. Can I ask what is your institutional practice of this acute pain and how you go about this thing?
Yeah.
In a nutshell.
Yeah. Acute pain, like usually we have a protocol. We have, for suppose the site of surgery is head and neck, or it's the site of surgery in the abdomen or in the limb. So for each type of surgery and each site, we have a different kind of pain relief that can be provided. For every, now with the advent of local anesthetics being very good for oncological survival, we use a lot of nerve blocks so that the patient is awake, doesn't have the side effects of narcotics and intense pain. Even for head and neck surgeries, there are blocks. So the area where the surgery is being done is first blocked with a local anesthetic before their approach. So the pain relief is much, much more intense. Also, we use drugs. Multiple drugs are being used and without the side effects. So that's called multimodal analgesia, where you decrease the amount of dose that you give of multiple drugs, and so the adverse effects are less and the patient has maximum benefit without compromising on their organ toxicity. That is our aim, and the patient should go home safely. I think we have seen much more survival and recurrence free rates now because of all this. Team spirit should be there with thing.
Okay, madam. Thank you.
Thank
Thank
you.
you for the nice talk, and
Thank you so much. Thank you
your
for having
valuable advices. Thank you.